اتفضل.
Bismillah ar-Rahman ar-Rahim. Good evening, everybody. My name is Wafa Aish, and I'm a consultant clinical dietitian. I'm so happy and glad to be with two dear friends, Professor Amr Matar and Professor Mireille Carvetian. Professor Mireille Carvetian, she's gonna moderate the session with me. Well, it needs two moderators for this, our excellent speaker, Dr. Amr Matar. Me and Professor Mireille, whom she is a professor in Toronto University. She's a lead in clinical nutrition as well. She is a lead in ESPN diploma in the Middle East and Gulf. Also one of the main committee organizers in MEAP and Middle East Interparliamentary Congress. She have a lot of publications in the Middle East, Gulf, and as well in Canada now, where she is teaching in Toronto University. Coming to our speaker, and Professor Amr Matar, of course, he is the president of Egypt Parental Society, and he's the head of clinical nutrition in the unit of Qasr Al Ain Hospital, teaching hospital. He's, of course, an ESPN teacher, the head of the ESPN diploma in the clinical nutrition. In all of that, Professor Amr Matar, distinguished leader in the field of clinical nutrition as well as in the critical care, with extensive expertise in advanced nutrition science across the Middle East and as well internationally. He has played a lot of bio-vital, let's say, role in developing evidence-based practices. He's very respected academic and clinician, author as well for so many numerous publications. He's a lead and in mentoring the healthcare professional, building collaboration that enhance quality of patient care. He had put a lot of protocols. Dr. Amr, if I will gonna talk, the time of the talk will be ending just giving his CV and Professor Mireille as well CV. So I will leave the floor for Dr. Amr to take us in a tour for enteral nutrition case scenario. We have a half an hour talk. After that, we have 15 minutes for your collaboration that be moderated with Professor Mireille Carvetian. The floor is yours, Dr. Amr.
Thank you very much, Wafa and Mireille. Thank you very much. Don't believe them. They are dear friends of mine and sisters, and but they want to exaggerate things. Thank you very much. I want to take every opportunity to thank our dear friend Khalid for gathering this very elegant group. Thank you very much. We start our case. But I hope you have already revised our previous presentation about how to prescribe enteral nutrition in ICU patient. This is a real life scenario and real case. We had it, and we are going to discuss how we can manage and apply the theoretical knowledge we had in the previous presentation and apply it on a real case scenario. I want you to take advantage of every bit of information you can get. So whether from the history, from the examination, and from the investigations. Our patient was 71-year-old man, has been admitted to the ICU. Has been admitted to the ICU for the first time because of fever, dyspnea, tachycardia, right-sided bronchopneumonia is diagnosed on X-ray. On history, 3 months ago before admission, he suffered from pain in the epigastrium. Reflux esophagitis was diagnosed endoscopically. The patient received proton pump inhibitor with only partial clinical effect. However, during the last 3 months, he has lost 8 kilograms of his body weight. Last week, he was unable to eat solid food and he could only drink fluids. Let's discuss what are the pieces of information we can get from this history without even go for examination. What is the importance of the word right-sided bronchopneumonia? If you can, I wanted an interactive session. I don't want a one-sided game. One is talking and the other are listening. Please as much as you can write down in the chat, or you can raise your hand to have it a live discussion. Right side bronchopneumonia. This can help me to diagnose something. Is there a difference between right side and left side? This is one thing. The patient is on reflux, on proton pump inhibitor for reflux esophagitis or GERD. Partial clinical effect. So we can, I don't see the chat, but if you have any answer of the right side, what right side, what does it mean? What's the significance of this word right side bronchopneumonia? Anyway, till I have your chat.
One person is saying maybe aspirated.
Maybe, yes, thank you. Why right side? It means I think it can be do aspiration. Very good answer, yes. Because we have the right bronchus more in line with the trachea. That's why the secretions coming up from the trachea down to the right bronchus is more in line, so can have right-sided bronchopneumonia more than left, which is difficult for the secretions to go to the left, and it's easier for the right side. So we can suspect it is due to aspiration. Okay. The proton pump inhibitor treatment was not effective. This is another positive thing, that this can be due to aspiration. The patient is elderly, 71. That means we can benefit from this when we are doing assessment.
Dr. Mahmoud said right bronchus anatomically in line with the trachea.
Excellent, Mahmoud. Bravo عليك يا Mahmoud. Thank you very much. Yes, very excellent. So what are the risk factors for pneumonia development in this patient? Yes, we have answered this. Old age. What happens with old age? We have what's known as protective reflexes, which are the swallowing and the cough reflex. They are decreased in elderly people up to 30% of the efficiency of these reflexes is lost. The patient on PPI, proton pump inhibitors, which causes poor absorption of vitamins like B12, magnesium, and iron. Also, he has already gastroesophageal reflux disease. As regards examination and the physical status during admission, the patient is on respiratory distress with oxygen saturation of 88%, on 14 liters of oxygen with a respiratory rate of 34 per minute. He's intubated and placed on FiO2 of 50%, PEEP 15, and pressure support of 12 centimeter water. These are ventilator settings that help the patient with pneumonia. His blood pressure is within the normal range, and after doing the intubation and the oxygenation and the ventilator settings, his saturation has improved and his respiratory rate is 14 per minute. He's COPD patient, alcoholic, and he does not have bowel sounds and is NPO. His weight is 70 kilograms and his height is 1.7 meters. What does it mean that this patient is alcoholic? What is the significance of this patient having COPD and he is an alcoholic patient?
Dr. Amr, a few of the attendees, Marwa, Duha, Dr. Marwa and Duha, they said they cannot write their answers. Can you please activate the answers if you want them to be aligned with you? Because
so it seems they can write only in the Q&A.
Yes,
not
exactly.
in the regular chat, but in the Q&A.
Yes. Yeah.
So write your answer, please, on the Q&A and
not in the chat.
Yes. Yeah. Thank you very much. So COPD patients are going to suffer a lot when put on a ventilator, and they are difficult to wean. An alcoholic patient, what's the significance? What, as a nutritionist, what is the benefit of such a piece of information? We have to take care of, yes, refeeding syndrome because of the deficiency of one of the vitamins which are very essential for the refeeding, which is vitamin B1, which is the thiamine.
Dr. Amir,
Yes.
Some people, maybe for connection reasons, couldn't get the introduction of the case. Would you be able to reintroduce it briefly? Because
Okay.
it seems it's a request.
The case very, very rapidly.
Yes,
He's a
thank you.
71-year-old man, has been admitted to the ICU for the first time because of fever, dyspnea, tachycardia. Right-sided bronchopneumonia is diagnosed on X-ray. On history, 3 months before admission, he suffered from pain in the epigastrium. Reflux esophagitis was diagnosed endoscopically. The patient received proton pump inhibitor with only partial clinical effect. However, during the last 3 months, he lost 8 kilograms of his body weight. In the last week, he could not swallow any solid food, and he was only on drinks. And he was substituted for pneumonia because of the old age PPI treatment and having a gel. Now, a question: does this patient need nutrition, and why? No, his body weight is already normal, and even his body mass index is within a normal range.
Some people said thiamine deficiency,
Yes,
risk of
very
hypoglycemia,
good.
malnutrition.
Very good. No, he is just admitted to a few hours ago. Or yes, because he's malnourished.
Even that you can. Yeah.
They're answering number 3.
Number 3. Okay, number 3 is right. Very good. We know that the patient is malnourished in spite of having a normal body mass index and a normal body weight for his height, but he lost already 10% of his body weight in the last 3 months. Therefore, if we have an NRS, which is National Risk Score, 2002, he has already weight loss, reduced dietary intake, and severe illness. We have 2 limbs of the NRS, one for the nutritional status and the other limb is for the disease severity. As regards the nutritional status, the patient is already, his food intake is less than 25%, which gives him score 3, while on the severity of the disease, he has severe pneumonia, which gives him score 2. So 3 and 2 makes 5. Together with being an elderly, so another 1 is added. So the total score of the NRS is 6. So this patient is at major risk of malnutrition. So treatment of malnutrition is, yes. Treatment of malnutrition is nutrition. And nutrition is not intra and parenteral tube. Nutrition is food, fortified food, ONS, orange sugar supplement. And then we can, if this is not enough, we can go for tube feeding, and if not enough, we can supplement with parenteral nutrition, and if there is a contraindication, we can go for parenteral nutrition. And parenteral nutrition is not the end of the story. We should go back to oral nutrition as soon as we can. Let us remind you with the 4 A's and 5 Q's, which constitute the nutritional plan or nutritional algorithm of management of any patient from the nutrition point of view. We have to 4 A's. We have to assess our patient. We have to determine the access, the second A. We have to know how to administer our nutrition, and we have to do audit or monitoring of our nutritional supply. So these are the 4 A's. We have to answer them. And while the third A means administration of nutrition, we have to answer 5 questions: when, what, where, how, and how much we are going to give this patient nutrition. If we complete these 4 A's and 5 Q's, we have a complete nutrition plan of this patient, and we are going to apply this to our case. بالعربي احنا بنقولها ايه، ندي ايه، قد ايه، امتى، فين، وازاي، لاخواننا اللي بيتكلموا عربي. So prescription includes the 4 A's and 5 Q's. We have to calculate the calories, proteins, and water, which is how much. Formula, what to give. Delivery route and access. Administration method. Rate of infusion is the how, and then the audit is monitoring. When we start nutrition in this patient, after weaning from mechanical ventilation, this particular patient, or after return of the intestinal sound, he doesn't have any audible intestinal sounds, or after both of them, or within 24 to 48 hours, he is malnourished. What do you think? Give me 1 letter.
Most of them answered D.
D is right. Very good. D is the right answer, because mechanical ventilation is not a contraindication to nutrition, and also overt signs of contractility or intestinal sound should not be required prior to initiation to enter nutrition. And this is the guidelines of ESPEN and ASPEN. They have already said that initiation of nutrition in any ICU patient within 38 hours is mandatory, even without doing any nutrition assessment. And this is very new in the ESPEN 2021. All patients staying in the ICU
Dr.
mainly.
Amr, can I just say something? There's
Yes.
a few of the attendees respectively and putting some questions. Dr. Amr will answer after the session finished. Dr. Mireille and myself, we will collect all those questions. We are not ignoring, we are collecting. So bear with us till he finished. A lot of questions already there of Dr. Amr.
Yeah,
So
we are
will not
at the very
interrupt.
beginning. Okay,
Yeah, till
that's
he
very good.
finished.
That's very good. That's very good. This one I like very much. So this is the latest ESPEN guidelines that all patients staying in the ICU, mainly for more than 48 hours, need medical nutrition therapy, should be considered. So where, remember the 5 questions, what, when, where, what, how, and how much. When, what is your choice, enteral or parenteral? Parenteral because the patient is on mechanical ventilation, or parenteral to prevent further aspiration because we have already, this is a very high possibility, or enteral because he has a working GIT. Yes, enteral because he has a working GIT. We have, as we have said before in the prescribing lecture, enteral, and then parenteral. You should try by every possible mean going through or reaching the GIT by any possible means, and you should use all the measures available to use the GIT for nutrition because of the importance of enteral nutrition. And we have said that we have more than 28 advantage of enteral nutrition, and we need to have them all for our patients. And this is the background of the guidelines that supporting that we should go for enteral nutrition even on mechanically ventilated patients. As long as we don't have any colics, no distension, no vomiting, no severe diarrhea or absolute constipation, our GIT is fine and we can go for enteral nutrition. Don't wait for the intestinal sounds. What route would you choose for this patient? Gastrostomy to maximize the nutrition provision, or NGT due to expected short time of need? Maybe usually pneumonia stays for less than 2 weeks if it is well managed. Or NGT, nasogastric and nasojejunal, is better. NGT is NGT is better in case of fear of aspiration. What's your choice?
Some people answered B, some people answered C.
Yes, both of them are right. We can take NGT because it's an expected short time. And we can, if you have a very solid evidence that this is an aspiration pneumonia, we can go for NGT to guard against more aspirations. And this is the scientific background of the guidelines supporting our review. We should start by stomach route, and then if there is any risk of aspiration or any intolerance, we can go for post-pyloric. How much, now then the next question, how much is the caloric requirement of patient is in your plan? Before we go for the questions, let's know how can we measure calories in general. Let's remember this together. We can measure our caloric needs by indirect calorimetry, which is the best in the ICU patient because of the dynamic process and changing, as we have said before, and we are going to remind you with this, that every day, maybe every 2 to 3 days, the caloric requirement changes in the ICU patients. So let's answer the question, how much is the caloric requirements of patient? What is your time plan to reach it? Is it 2100 or 2450? Start with full dose from day one? Is it 1750 or 2100 per day? Start with 50% of the requirements day one and gradually increase according to the tolerance, or it is less, we're starting with 25 in day one and advance according to the tolerance. Like this patient
We
A.
selected 3, which is 25%, 1,500 to 1,750. Mostly. Oh, now I have answers 2, which is 50%. Mm.
Actually,
So
it's true because of what I'm going to tell you in the next slide. And we have only 3 methods of measuring or calculating our calories. The indirect calorimetry, which is the best in the ICU patient if available. If not, we can go for what's known as predictive equations like Harris-Benedict and others. If we don't have them, we can go for simplistic weight-based equation, which is according to the Espen and Aspen 25 to 30 calories per kg per day. We don't start directly with the full power, as we are going to see. And I'm reminding you with this figure we have discussed in the previous lecture that we have different energy expenditure levels all through the first week of admission to the ICU. In the first early period, which is the first 2 days, we have very lower caloric needs at this time because of the high production of endogenous energy, with leading to high endogenous production of calories. So the need in the first 2 days is minimal. It is the red arrow. It's a difference between the black and the gray. In the late period, which is the rest of the week, which is from day 3 to day 7, there is a higher energy deficit and a higher risk of underfeeding. And there is sometimes we need for supplementation at this area. So the caloric requirements in the first week of ICU patient is as follows. And this is very important to know. If we are using indirect calorimetry, we go for hypocaloric feeding all through the first 2 days. And then we start reaching our target from day 3 to day 7, which is 80 to 100. This is because we have numbers, already accurate numbers by the indirect calorimetry. If we don't have, and we have already predictive equations, you go for hypocaloric feeding all through the first week, which is 70% below estimated needs. Hypocaloric feeding means 70% or less of the caloric requirements or needs. Eucaloric feeding means I'm giving the requirements exactly. Overfeeding means that I'm giving more than 110 of the caloric requirements of the patient, and this is also dangerous. If I don't have the indirect calorimetry or the predictive equation, we can go for simple equation. In the first 2 days, don't exceed ever 10 to 20 calories per kg of this patient. And then in the rest of the week, we go for not more than 20 calories per kg. So the golden rule in nutrition is start low and go slow, especially in the ICU patients. So how much fluid? Water. We all know we have to calculate calories, and already you have finished this. Water and proteins. What about water? We give usually 30 to 40 calories per kg per day in adults. And this is usually, we can go with 1 ml water to 1 calorie requirements. What formula? Here is the what. What formula type would you order for this patient? High fat carbohydrate ratio formula because of mechanical ventilation and COPD patient to improve the weaning and reduce the carbon dioxide production, or high caloric formula because he is at high risk of malnutrition, or standard polymeric formula. Yes, ABC or 1, 2, 3. مفيش حاجة في الchat. Okay, it is.
So the answers between 1, 2.
Actually, the answer is 3. One only in case if the patient was COVID. The answer is 3. Usually, in 95% of all patients, you start with what is known as standard polymeric formula. This is to start with in most, if not even in all types of patients. We start with standard polymeric formula. What's standard polymeric formula? It is a formula that contains 15 to 20% of energy from whole protein, 30% of energy from fat or less, 50 to 55% from carb. Every 1 milliliter of this formula contains 1 calorie. So 1 calorie per ml. And it contains 85% of water. So it is not all of it water. It's only 85% of water, and with or without fiber. This is standard polymeric formula. What about the water? So now we said that we need for this patient 30 to 40 milliliter per kg. So we need around, yes, 2,100 milliliter of water. We should subtract the water in the formula and add the deficiency. What does it mean? So water in the formula is, if we said that the patient is going to have 1,800 calories per day, and this formula contains 85% of its content from water. So the water content of this formula is 1530 milliliter. So I need additional water because the patient needs 2100 milliliter of water, and the formula supplies 1530. So the deficiency is around 600 milliliter. Yes. How can I can give this in the form of sterile water? Yes. And I should give them
Some
as
people wrote 1 cc per calorie per kilogram. Some people wrote 1 cc per calorie per kilogram. And Mariam said by flushing. That's mostly the answers that received.
Yes. It comes back to the
By
same.
flushing and by what the answers by flushing. Somebody
Yeah.
wrote by crystalloids, and one said 1 cc per 1 kilogram.
Yes.
Some wrote number 4. I don't know for what number 4. If
We have no, this is no contradiction of this, but we can give this in the form, if we are going to patient, we are giving him continuous feeding, we can go for every 4 hours, can give 100 milliliter of flush. And if we are going to for a bolus feeding, we can give this water before and after the feeding. What about the protein requirements? Protein requirements, Hannah, what about the protein content of the formula? Is it the recommended dose of protein already can be supplied through the formula, or I need to do another thing to complete the requirement? In the formula, which contains about 1800 milliliter, for every 100 milliliter, it contains 3.8 gram of protein. So the total protein from the formula per day is 68 gram. The requirements, according to the Aspen, it is 1.3. According to the Aspen, it is 1.2 to 2 grams per day in the ICU patient. We are giving usually an average of 1.5 gram of protein per day. So 70, which is the body weight of the patient, multiplied by 1.5 is around 105 grams of protein, while the formula supplies 68 grams of protein. So the difference is about 37, let's say 40 grams of protein. How should I supply this type of protein? We are going to answer this later on. And this is the formula we are using. Do you think the formula is supplying enough protein? Yes, I said no, we have deficiency, we have to supplement this protein. And what to do then? How can we supplement the deficient protein? It's around 40 grams of protein per day should be supplemented. Can we use a high protein formula that matches the needs? Or we add the deficit as protein supplements separately? Or can we add supplemental protein parenterally? What do you think?
The
If
answer
the protein in the
number
formula
1.
is less than the needed protein requirements of the patient, what can we do?
People answered 1. Some people answered 2. Some people said 1 A and B, 1 and 2. And some people mostly 1, which is A. That's mostly the answers. So
All
the
of
answer
them are right.
only 1 said C.
We can do the 3, no problem.
Yeah.
We have
I
to
wanted
give
to-
the protein requirements. Yes. Anyway, if I have already a high protein formula that's available that can give me the requirements, I go ahead for it. If I don't have, I can supplement this separately by a whey protein. We have some sachets of whey protein, or I have some cans that contains whey protein, which is around 5 grams per scoop. We can do it in this way, or we can, even if you don't have this or this, we can supplement this parenterally, no problem. But you should give the patient protein, because if you give less than 80% of the protein requirements in ICU patient, a very high rate of mortality is expected to be there. What are the 4 safety steps you should do before giving the order to start enteral nutrition? I emphasized these 4 steps in the lecture. I hope you still remember in the previous lecture. Yes. I will wait for you to tell me what are these 4 things I make sure before we start the enteral nutrition. It is a safety procedure. I should be aware of them, and they should be there before I give the order to start the enteral nutrition.
Some people said where to answer. Please answer here on the questions and answer, not on the chat. Thank you. Check GI function, intestinal sounds, and confirm NG feeding, check the position,
Position, what position? Position of what?
check the position of NGT,
Yes.
hemodynamics and electrolytes,
Bravo.
and X-ray, hemodynamically stable, confirm position NGT.
Thank you very much. You have said them all.
stability,
Yes.
upper GI, function of GI. MashaAllah, all of them answered correctly.
Yes, these are the 4 steps or the 4 safety measures should be there before you give the order of starting enteral nutrition. Confirm that the patient has already a hemodynamic stability. Confirm tube position before each feeding. Elevate head of the bed 30 to 45 degrees and check electrolyte serum level and correct if there is any deficiency. Very good. Thank you very much. How much calories, water, and proteins does this patient need? احنا قلنا خلاص it's around 1800 calories as we did from the simple equation, but we don't have at that time the IC. We have to give 2 liters, 100 milliliter of water and 105 gram of proteins. How? We are going to administer our formula. Should we use the bolus or the continuous feeding in ICU patient? Yes, we go for, as
Most
the
of
more
them
critical the patient
continuous.
is, the more we go for continuous feeding.
Some answered bolus, but the major continuous.
It goes for, yes, continuous is the right answer because in critical ill patient, the GIT is not well prepared to receive a good volume of food as a bolus. So it's better to give it in small amounts over longer time for tolerance to be there, not to have a great deal of intolerance problems. So we start for continuous. We have 4 methods of administration of our feeding. It's either continuous, which means through a pump or a gravity, usually over 16 to 24 hours, or a bolus, which is by gravity or with large bore syringe over 10 to 20 minutes, less than 30 milliliter per minute. And this is very important thing. Why? When you are using bolus, which is more physiological, by the way, but we cannot use it in most of the critical ill patients. The problem with the bolus is that you have to have patience while giving the patient the bolus. 30 milliliter at the most every minute, not more than this, not to have intolerance or regurg or some colics or vomiting. We can, if the patient is still having some intolerance with the bolus, we can go for intermittent feeding, which is a prolonged bolus, not over 20 minutes, over 1 hour. We can go for 1 hour, and this can give a better chance for better absorption. And we can go for cyclic, but this is not usually done in ICU. It's in an outpatient who is mainly on home parenteral nutrition. We can, or home enteral, we can give him during the night all his requirements and can give him a free time all through the day. This is how to write down the order to calculate. If you are going to do the bolus, we said how many milliliters the bolus over 20 or 30 minutes, whatever you are going to give the order, or continuous 20 milliliters. We start usually with 20 milliliters per hour and then increase gradually every 12 hours according to the tolerance of the patient. We have the continuous method or the bolus method. The continuous method, usually we are using open method. An open method means we have this empty bag and we can fill in with whatever we have. We can with a formula, with a blended powder, even with command blenderized food. If we don't have this or that, or we don't have ready to use formulas, we can even use, but we have to take care of something if we do this. So continuous, open method, or closed method. We have a sterile bag already with a sterile influence head, and we can go for it. We have to take care of 2 important things: the rate-based feeding or the volume-based feeding. If I'm telling the patient or I'm giving the order that this patient is going to have a continuous feeding on the rate of 40 milliliters per hour, and this patient already was scheduled for a CT scan or an MRI and spent 4 or 5 hours there we are going to stop the feeding for these 4 hours. If the rate is 400 or 500, 40 or 50 or 60, so 60 multiplied by 4, this is a lost feeding time. And this is known as rate-based feeding. So to make up for this, we can go for what is known as volume-based feeding. If I already lost 4 hours, 5 hours, or whatever the time of lost without feeding, I should compensate in when the patient comes back to the ICU or to the ward, and do it according to what's known as volume-based feeding. So I make up for the lost volume of feed through the MRI or the T or whatever. And we have some volume-based feeding schedule to make it easy for us to calculate the lost hours. Now, after we have already given our patient, we have to assess for number 4, which is the...
Amr, there's a
Amr.
comment, not a question, from
Yes,
Sana,
yes,
saying that usually we give over 20 hours with 4 hours bowel.
Our rest, yes, we can do this. طبعا, we do this, and this has many beneficial things. Most of them is give rest for the GIT to recover, and then the most important is better control of the glucose, because usually the glucose level is lower during the night, and if we give high dose of glucose in this time, the glucose control during the ICU is going to be a little bit difficult, and many other things. Very good, thank you very much. How to assess tolerance of feeding? احنا قلنا we have to remind you with the 4 A's: assess, access, administer. We have finished all this with the 5 questions: when, where, how, and how much, and what. And then number 4 of the A's is how to audit, how to monitor our nutrition. We have to monitor 3 main things: adequacy of nutrition, intolerance, and complications. How to assess tolerance feeding? Is there any nausea, vomiting, diarrhea, abdominal pain, colics, distension, diarrhea, or GFR? GFR دلوقتي is not recommended to be there unless we have calculated more than 500 SEC if we tried once. And it should not be there alone. It should be there with another sign of intolerance, whether it's vomiting, diarrhea, or whatever. In case of intolerance, so I have intolerance, what should I do? The recommendation is to give erythromycin and metoclopramide in this order. We start with erythromycin every 12 hours, and for 24 hours. If this is not effective, we can add the metoclopramide 10 milligram every 8 hours for another 24 hours. If both of them are not effective, we can go for post-pyloric feeding to combat the intolerance and to improve the tolerance of the patient. According to the formula I'm putting on for the patient, we have what's known as hanging time. What's the hanging time? It is the safe time of hanging the formula with minimal risk of bacterial contamination. So I'm afraid of bacterial contamination if I'm putting my formula for a long period on the stand because of bacterial contamination. Hanging time is an important factor that contributes to bacterial contamination in nutrition. It is recommended to be not more than 2 hours if I'm using blenderized food in our kitchen, or not more than 4 hours for reconstituted powdered formula. I'm putting in the bag. Not more than 8 to 12 hours for sterile formula, but put in an open system. I showed you the open system. And no more than 24 hours for sterile formula. Not 48, only 48 is wrong. Not more than 24 hours if I'm using sterile formula in a closed system. So hanging time is important, not to put the patient in the danger of having bacterial contamination. Our patient's parameters improved and is ready now for weaning from the ventilator. Please answer this question. How would you stop? Would you stop the enteral nutrition before extubation? So we are going to extubate the patient. He's ready for weaning. So I'm going to extubate the patient. Remove the endotracheal tube from the patient. Would you stop the enteral perforation before doing that? And how will you provide nutrition after removing of the endotracheal tube? have
Some
three.
answered no. NPO, yes, yes. No need to stop. Yes, for a few hours. Yes, better to stop before the extubation. No, we would aspirate the stomach 2 hours maximum, clear food first and then soft.
Very
After
good.
check the pressure of the tube.
Yes.
Manal.
It's one of the three reasons. Yes, the first one is yes, I'm going to stop enteral nutrition, and then I'm going to use the oral route when the patient has good airway reflexes. Yes, I'm going to stop EN, and I'm going to use the tube NGT and gradual oral nutrition. Or no, I will not stop enteral nutrition. I go for continuous gastric feeding.
The answer between 2 and 3, doctor. Some people say 3, some people said no, 2.
Actually, it's 2.
Yeah.
We should stop enteral nutrition before extubation for fear of aspiration. Yes. The one who said that we can do a gastric aspiration before extubation, yes, if it is about, yeah, and the patient is now in a very good condition and he's coughing on the tube and I need to remove it, before I remove it, I can go for aspiration for a while, 5 minutes or something. Yes, I can do this. And then, so I have to stop enteral nutrition for, usually, if I'm going to have I'm giving a very blended food for 6 hours. If not, the formula is 4 hours. If not, I have to do extubation now. I have to do aspiration of the NGT, suction from the NGT to empty the stomach before extubation. Now, after successful weaning, I have already removed the endotracheal tube. Will you remove the NGT? Well, I keep it in place.
Some said yes. Before removing, make sure they are tolerating oral. Yes. Yes, if tolerate oral, no. 50%. Some people said no, no. After checking the gag reflux, no, prefer no. Yes, if converting to oral, yes.
Please,
Yes, if
please, don't remove the NGT.
depend on the case, some people said.
Please, not. You have to assess first before removal. Please
Yes,
don't remove the NGT right away with the endotracheal tube. Keep the NGT in place because there is something known as post-extubation swallowing disorder that could be prolonged for up to 21 days, mainly in the elderly and after prolonged intubation. And it happens in more than 50% of patients. Some people can suffer from post-extubation swallowing disorders up to 4 months. So I have to make sure that the patient does not have a swallowing disorder by some tests, by swallowing water and he's not choking, and a good reflexes is there. The swallowing and the cough reflex is there. And sometimes we need a speech expert to tell us about this. In non-extubated patient with dysphagia and a very high aspiration risk, خلي بالك من this, take care of this. Post-pyloric enteral nutrition, or if not possible, temporary parenteral nutrition during the swallowing training with removed nasoenteral tube can be performed. ده نقدر نعمله in this patient. Nutrition weaning. So now you keep the NGT that to make sure that the patient is having a good oral feeding up to 70% of the requirements, خلاص, safely, without need for supplementation through the tube, through oral only. At this time, you can remove the NGT. So weaning for nutrition, we can wean first from the pump and wean from the tube and then wean from the formula. Keep the formula because we still have care after discharge from the ICU. Your job does not end by discharging the patient from the ICU. It will continue. You have to take care of your patient because now we have now what's known as post-ICU or chronic critically ill patient. Chronic critically ill patient. We have still patient needs to be attended for after a discharge from the ICU, and many studies have proven that post-ICU nutrition state is most of the patient needs to be attended for a longer period than a discharge from the ICU. So we have to recommend these things after discharge. We have to tell the patient to have frequent meals, 2 to 3 snacks, the requirement should not be less than 35 calories per kg per day. We can raise up the protein requirements up to 2 grams per kg daily. The protein, especially, we have to use the branching chain amino acids and the leucine in particular. Vitamins and trace elements should be supplemented altogether. Physical exercise should be added. And now physical exercise is a supplement, and it is a mandatory in the ICU patients, even if they are on mechanical ventilation. It is one of the highly recommended procedures in the last ESPEN guidelines 2021. We should supplement our patients with exercise in the ICU to improve the outcome of our patients. One thing I've already forgot, what about the trace elements and the micronutrients in our patient here? Any formula, when supplied to the patient, if it is more than 1,500 calories per day, it should contain the daily requirements of vitamins and minerals. So we don't have to worry in our patient about supplementation with vitamins and minerals and micronutrients. Last but not least, this is a summary of the enteral nutrition form. If you follow these 16 steps, you are going to be completing your nutrition plan for any patient. So I leave it with you, and I already, I think I left it with you in the last presentation. And thank you very much. I'm waiting for your questions.
My God, you have a lot of questions. Dr. Mireille, while we are chatting and I'm answering the questions and their answers, she's putting all the questions together. Yalla, ya Dr. Amr, get ready to rock.
Yes, I'm ready.
A lot. Dr. Mireille, the floor is yours.
Well, what I did is I dismissed all the answers for exam questions that you had. So I've left right now in the open only the questions that are still waiting for answers from you. So first question is from Hamad Irfan. When should nutrition be provided post-operatively? As soon as possible or waiting for bowel peristalsis?
Post-operative nutrition should start as early as 6 hours in the first 24 hours, as early as 6 hours in some centers, as long as we have a working GIT, no problem. And don't be afraid from that enteral nutrition is going to jeopardize the anastomotic line and going to lead to leak in the operation. This is not the case. It's on the contrary. Early enteral nutrition is accompanied by better deposition of fibers and collagen on the anastomotic line. So we have to convince our surgeon that this is better for your patient and even for your operation.
Okay, thank you. When to stop enteral feeding in case of vomiting or diarrhea?
Severe vomiting or diarrhea is an indication for parenteral nutrition and to give rest for the GIT.
I think it is 500 ml, right?
Or more, yes.
Yes. Okay. I would like to ask, how should EN prescription be adjusted in patients with critical illness related to obesity or severe malnutrition?
Very good question. Very good question. As regards severe malnutrition, we calculate our body according to the ideal body weight. As for the obese patient, the ICU, the ESPEN says that we go for what's known as adjusted body weight. The adjusted body weight means the actual body weight minus the difference between the actual and the adjusted divided by 0.3.
How do you adjust enteral nutrition prescription in patients with multi-organ failure? This is an extremely difficult question. We cannot answer it in one simple. It depends according which type of organ you have is failing. If you have liver, we go for a special consideration. We are a kidney, for example, in a kidney patient, we have acute kidney patient, we have a CKD patient, we have patient on dialysis, and every one of them has different requirements of proteins, water, and minerals and electrolytes. So it depends. Okay. In case of pulmonary distress, isn't it better if we reduce carbohydrate ratio to less than 50%?
Yes, it is a maneuver that done by some centers to reduce the carb, because we are going and doing this, we are going to reduce the production of carbon dioxide. That's to say, we are going to improve the respiratory function. We're not going to have less respiratory failure, and we are going to have a better or easier weaning from the ventilator. I agree in some cases.
Somebody's asking, you shared a volume-based schedule. If you can share that again.
Yes, no problem.
Okay. What is the best strategy to shift from continuous feeding to bolus feeding?
Again, please, Mary.
Yes, from continuous to bolus, what is the best way? When would you feel comfortable to shift?
Yes, this is a very good question. Actually, this is known as transitional feeding. Transition feeding, yani you can move from one way of feeding to the other. So as long as your patient is tolerating and we don't have any sign of intolerance, we can already decrease the continuous and start giving bolus. And we start by giving many times of boluses. So we have to give boluses from 8 times per day, for instance. That means every 3 hours. And then we can give increase the duration between boluses and increase the time. So we can give every 4 hours. And then every 6 hours, and this is the best. So
and if I may ask, usually when the patient becomes stable and they are ready to move to the regular ward, that is a good indicator for a dietitian. Like when the medical team decides that the patient is good to move or get extubated and so forth, these are stability indicators for dietitians.
I agree very much. Thank you.
Thank you. Another question, in case of sepsis, critical condition, how to initiate enteral feeding?
You have to resuscitate the patient first, and we go as usual. We go enteral nutrition as usual. But
when you mean resuscitate, electrolyte resuscitation? Yes. Or?
Yes, we go for enteral. There's no contraindication for enteral septic patient, but we have to resuscitate first.
Wait, oh, sorry, it's a long one. Okay. How does indirect calorimetry improve accuracy in determining energy requirements compared to predictive equations in critically ill patients? And I think this is the second question. What are the limitations in regular practical routine life, in using indirect calorimetry?
Yes, that's very good questions. Well, anyway, let me show you this, and it is going to be make it more clear if we go back for the figure, and you see how important is the indirect calorimetry. This is the energy in the acute phase, which is the first week of admission to the ICU. This is day 1, day 2, day 3, day 4, up to day 7. In first 2 days, there is a lot of secretion of stress hormones that leads to higher production of endogenous energy production, which is represented by the gray curve in this figure. Okay, and this is the total energy expenditure, which is the dark red curve. In the first 2 days, we have a high energy production from inside because of a lot of stress hormones, and we have only a small lower caloric needs to be supplemented from outside. How can I know this? By indirect calorimetry. This is so I have to measure this. What happens after day 3? Day 3 here, the gap starts to be more and more between the total energy expenditure and the endogenous energy expenditure because of depletion of the stores. خلاص, no more adrenaline, dopamine, glucagon, cortisone, and growth hormone. So the gap is higher because the endogenous energy production is. How can I know this? Predictive equation cannot give me these changes. It is a dynamic process. So I have to measure it accurately and clinically. So I can do this only with indirect calorimetry. And so I need to do repeated measurements of the indirect calorimetry. But actually, using the indirect calorimetry has a lot of specs to be there. The patient should be stabilized, and the patient should maybe for the last 20 minutes without feeding, and the feeding, many requirements for measurements of the indirect calorimetry. And by the way, predictive equation is giving us a very, if we compare it with the IC, it is there is much difference between them. It's not an accurate in 70% of patients. Yes.
Also, I wanted to just like highlight how exaggerated the situation is. The first 3 days, because of cortisone, around 350 grams of carbohydrate is produced endogenously. So if we multiply it by 4, that is around 1,300 calories.
That's enough for the
Yes, like when I started my career early on, and I want to share this so that I think everybody has felt this. We used to have ICU patients having hyperglycemia because as a dietitian, I tried to start feeding them. And then we had to give them insulin, you know, like gliding scale, and increase the insulin because we didn't understand that in the first 3 days, we have this already endogenous production. Yes. So here comes, truly, it is important to understand what Dr. Amer is saying and tailor-make the feeding, because sometimes doing too much is as bad as doing too little. So doing the right thing, indirect calorimeter might actually help that doing the right thing.
Yes. And I want you to remember this figure, please. Yeah, and you put in mind on just get a snapshot of it. This is very important. Yeah. Okay, next.
All right, just a minute. There's too many questions, but I think we're ending. Two more, I think, huh, Dr. Amer? I know you've been very patient. Yeah, how do you circulate daily caloric requirements for adult ICU patients receiving mechanical ventilation? I don't know. Sorry. How do you calculate? Sorry. How do you calculate daily caloric requirements? This is in case you don't have indirect calorimeter. In case you don't have indirect calorimeter in adult ICU patients.
Yes, very good. And I will remind you with this, and this is also very important. You don't have the indirect calorimetry, you go for predictive equation, and the results, you give 70% of the results you have from the predictive equation. And we start early by 50% of the calories, and then increase gradually. But all through the first week, if you're using the Harris-Bennett, for example, you go for the hypocaloric feeding, which is 70% of the Smith units. If you are only using simple equation, you don't exceed 10 to 20 calories in the first 2 days, and keep on the 20 for the rest of the week. So
yes. Somebody is asking, with indirect calorimeter, how often should you be doing in the ICU if you have one?
Every 3 days. You should, and على طول كده. In the first 2 days, you don't use indirect calorimeter because the patient is not stable. And one of the requirements of the ICU, the patient should be stable. After stabilization of the patient, you take the control, and then after 3 days, you get another.
If gastric residual is above 500, after how many hours should we check again to make a protocol?
4 to 6 hours.
Kitchen feed versus ready-made feed, which one is better?
I'll tell you the truth. The better طبعا is ready-made because it's sterile, and it is safer, and we know what's in. Kitchen or blenderized food is difficult to do, but if you don't have, and we do this in Egypt, we do blenderized food feeding, because sometimes in the last 2 years we had suffered from importing things from outside. So nutrition is better than no nutrition. If you don't have the ready-made or ready-to-use formula, you go for blenderized food. But you have to be careful with the precautions, like that it should be hanging not more than 2 hours, and should be repeated, and all we have said through our lecture. But you go for ready-to-use, it's better طبعا, and it is recommended. If you don't have at all, we go for blenderized food, and no problem about this. Nutrition.
One last question. I'm trying to prioritize between the questions. I will tell you, everybody is extremely excited with this lecture. Very interactive. I think when we have so many questions, it means the lecture was accessible and people could understand and relate. So this is a good testament in trying to go through. With carbohydrate ratio for diabetics, let me see, usually have high blood sugar levels. What type of formula should you be considered best to avoid glucose spike?
Well, this is a very good question. Good question. Should we use a specialized formula for diabetic patients? Why not? Why not? We have one Pro, and it's good for the patient in ICU usually, and it is proved to be better for control of the blood glucose in ICU patient and diabetic patients. I use one Pro.
Dr. Amir, if I may intervene, at the beginning, when it is less than 50%, we can use any because the amount of carbohydrate will not really be able to spike up. So maybe if it's cheaper or more available, yes. But once you reach 75 and above, it would be good to use your specialized formulas. Is there a common medication that might increase the risk of feeding intolerance?
Well, feeding intolerance, tell me some procedures and not only medications that can lead to. If you use a formula that's coming out from the refrigerator, it will cause. If you give, if you don't follow the recommendations about giving your bolus and you give it very rapidly, it's going to be give you an intolerance. If you are using oh my God. I mean, the formula you are using, if it's an osmolar, a high osmolarity of the formula can lead to intolerance. So you have to check all of these things before you go for this is an intolerance. You have to revise your procedures. You have to revise how you are administering your formula. You revise how is the formula is given, the temperature of the formula, and so on, the rate of the formula, and the osmolarity of the formula. All these things can lead to intolerance.
And somebody asked if they don't have, I think we're going back to that because I understand its practicality. If they do not have indirect calorimeter, what do they do?
We have answered this already.
Yes, but I would also say that the volume of carbon dioxide on the ventilator can actually help estimate energy needs within certain situations where there is no fever. So if the hospital does not have an indirect calorimeter, they can check into some formulas. If the person is on an intubator, read the volume of carbon dioxide and use that as a way to estimate indirect calorimeter. It's not perfect, but it's there. Because I keep on seeing this question many times, so I'm just trying to give a practical solution. I think our time is up. The questions are not, but we had to prioritize. I hope we met with everybody's questions as much as we could. One last thing, they're asking for your summary slide. If you could also reshare that so that they can see it.
Okay.
Yeah, there it is. Yeah. Thank you so much, Dr. Amir. This was fantastic.
Thank you for the very good moderation.
Exciting.
Thank you very much. And I hope see you live soon, inshallah. And very good moderation. Thank you very much. Thank you all. And I hope you, if you have any questions, you can
There's a lot of questions about CKDs, about starvation, but those needs a lot of itself. They need a lecture by itself. So maybe in the future. Thank you so much, Mireille, for all this summarization.
For everyone.
Thank you for.
You can contact me as for our students or our attendees. You can call me or you can get in contact with me on my mail. My mail is amrmatar@hotmail.com, AMRMATTAR@hotmail.com. And thank you very much, everyone.
Thank you, Dr. Khaled Suwaifi, Dr. Amr Matar, and Dr. Amr also, all the team in the WW for this amazing preparation. Myself and Dr. Mireille, thank you, Dr. Amr, for amazing interaction from the audience. It was wonderful. Thank you so much for a nice evening. Have a nice day. Thank you so much. Bye-bye.
Assalamu alaikum.
Alaikum assalam.